Hello to all. We are here today at UAB for a special coffee conversation. And I'm here with Forge. My name is Summer Spain. I'm one of the directors at Forge Breast Cancer Survivor Center. And I'm here we have a very special guest, Dr. Gabriela Halder, which is a urogynecologist. And we have a really interesting subject that we would like to talk to everybody about today, which is the pelvic floor health. We have the questions and the answers that we're going to do. But before I do, I would like to introduce everybody. Today I'm here with Yadira, which she's one of my colleagues at work that works with our client services in the Hispanic department. And we have Rina Benavides. She is actually one of our clients, volunteers, and a breast cancer survivor here today with us to join us in this on the coffee conversation that we're doing today.
Okay.
And so anyways, I wanted to start off with the first question. Dr. Halder, when would it be a good time for somebody to schedule an appointment with you?
Yeah, I get this question commonly, and I tell people just if you're having symptoms. So if you have leakage of urine and it bothers you, come see me. If you feel like you have a bulge in your pelvic floor and with a lot of pressure, come see your urogynecologist. But otherwise, you don't need a routine exam. You don't need to routinely see your gynecologist. In fact, I tell people, if you have a bulge and it doesn't bother you, we're not going to treat it. It's not ours. What we need to do is help people feel better.
Mm-hmm.
So that's different from cardiology or cancer therapy, right? Where if you see something, you have to treat it. Not with your gynecology. We only treat it if it bothers people. So that's why.
So you're like treating the symptoms?
Exactly.
Of what?
So
the discomfort.
Exactly. So if you don't have symptoms, there's no reason to go to your gynecologist. And if you don't have symptoms, that's good. That's a good thing. Don't come visit us. You don't have to visit us. One less doctor to deal with. But if you are struggling in any way, everybody's definition of what they find hard to struggle with is different. I have women who leak a lot and they're like, yeah, I'm fine. Like, it's not a big deal. And I have women who leak a little and they're like, this really bothers me. So whatever that definition is for you, you set that definition, and whenever it bothers you enough, then go see a doctor.
I do have a few questions.
Yeah.
I want to ask you about the overactive pelvic floor pain. How can you relieve that?
Yeah, good question. We start usually with physical therapy. So that the treatment for that is usually pretty long because we have to teach you how to relax those pelvic floors. So really working closely with pelvic floor physical therapy. You usually go about once a week, and the length of it will depend on how you're doing. But in my experience, it's usually a couple months of learning to relax the pelvic floor, especially if you're having like pain with intercourse, for example. Preparing you to have intercourse by relaxing appropriately. Because a lot of it is mental, right?
Yeah.
All of that just takes time. But that's the primary treatment for it.
I was going to ask you, does menopause increase the weakness of the pelvic floor muscles?
So that's a really great question. We don't really know the answer to that. What we do know is that the vagina has estrogen receptors, and when we take that estrogen away, women tend to have more symptoms. Mm-hmm. Exactly why that happens, we actually don't know, believe it or not. So for certain problems like recurrent bladder infections, which tend to happen in older women, or even urinary urgency, we do give vaginal estrogen to the vagina to help with that. But it's also not the primary treatment. Unless it's repetitive bladder infections, then actually vaginal estrogen cream is the primary therapy for that. But it's not how exactly menopause impacts everything on the pelvic floor and increases your risk of incontinence or prolapse. We actually don't fully know.
Right. As a cancer patient, which is not estrogen, positive, is there any other alternative that I could use? Or is it safe to use that estrogen cream?
That's a really great question. So it's safe. And we've done a lot of really, really, really large studies testing to see if vaginal estrogen cream is okay in breast cancer survivors, even women that are in active treatment. And it is because the type of estrogen that you get in the vagina is different from oral. Mm-hmm. And from what we know, really, well, the dose in the vagina is very, very low, super low. And so the amount that gets into the bloodstream is really, really, really negligible. And they've followed women who have been cancer survivors and received vaginal estrogen cream, and there's been no rates of recurrence at all. So, but I always advise women, I say, talk to your oncologist, but in more recent times, overwhelmingly, the oncologists say, no, it's actually really good for you. In fact, there have been some newer studies that have come out that have said, that have shown that women who are survivors of estrogen cancers, which could be, it's not just breast cancer, it could be like other gynecologic cancers, they actually do better with estrogen cream.
Okay.
So,
Wow.
so
That's
it's
good to know.
yeah.
So it would relieve issues with the vaginal area as well as the bladder issues that you may
It could. It depends on the type of bladder, but it could. For example, a lot of women who have had anti-estrogen therapies, their vaginas are really affected, so they're getting a lot of bladder infections.
Mhm.
And there really is no better treatment for that. I want to say no better treatment than vaginal estrogen cream. And so that's why we really emphasize that it really is better for you, because what you would hate to do is not treat the problem and then also give them therapies that don't work.
Right, because I have noticed a recurrent of urinary tract infections, things that weren't there before,
Yeah.
cancer treatment, and the fear of the estrogen, being back in the body. So do you think this is something I should talk to the gynecologist?
I think you can. And I think you can. Yeah, I think that'd be great. And then a gynecologist or a urogynecologist can prescribe vaginal estrogen cream. It doesn't have to be necessarily a urogynecologist. I would talk to both.
Another question that I have is the cancer treatment. Some patients, or in my case, we take medicine that reduces the bone density.
Mm-hmm.
Does that bone density affect the pelvic floor?
Not that I know of. Not that I know of. Now, it depends on how bad your bone density is, and if you have osteoporosis, it can increase your risk of fracture of the pelvis if you fall or something like that. And then that would impact your pelvic floor and risk of incontinence and all that. But by itself, it shouldn't. It shouldn't. It's much more. It shouldn't, because the muscle can exist even with The muscle can be strong even in osteopenia and osteoporosis.
So that's good to know.
Yeah.
Another question is that with the fecal incontinence,
Mm-hmm.
we see that a lot with some medications.
Mm-hmm.
What can you tell me about that?
Yeah, I think so. If the medication is giving you diarrhea and diarrhea is giving you fecal incontinence, in general, you can take over-the-counter antidiarrheals like Imodium, but I would definitely talk to your oncologist about that just to make sure there's no interaction with the medicines. But usually that treats it. Between Imodium and fiber, a good fiber diets are the best way to go, but I'll tell you it's so hard to get all of your fiber in the diet. So it's usually 25 grams a day, 20 to 25 grams a day, depending on your age, is a daily recommendation. And it's, as someone who's tried, it's really hard to get that. And then also, if you're just not feeling good because maybe you're going through chemo, it makes it even harder to get it in. So I would recommend talking to your doctor and seeing, can I use Imodium? And when it comes to fiber, what fiber alternatives exist? A great fiber alternative that I love is Benefiber.
Mhm.
You can get it over the counter. Yeah, you can get it at Target, Walmart, CVS. It's a big green tub.
Mhm.
I personally use it. I have no shame in saying that. I personally use it every day. And what I love about it is that it doesn't smell like anything or taste like anything. So I put it in my coffee.
Put it in anything.
Yeah.
In the morning.
I just put it in my coffee. And you can use it up to 3 times a day. That won't give you all of the fiber you need in a day, so you'll still need to supplement with food. But that's what we want, right? Is you do a little bit with diet, you do a little bit with supplement. And that helps with diarrhea and constipation.
Constipation, awesome. Some of the medications after, the chemotherapy definitely affect, the bowel movement. So it could either be constipation or diarrhea. So that's good to know.
Yeah.
I was going to say at Forge, the one thing I think that I've heard a lot of clients complain about is just bladder infections and overactive bladders. Is there any new treatment or new studies that you guys are working with about that? Because I know there's bladder spasms. It could be because of the treatments, but just in general, women, as we age, we have issues with that.
Yeah, I'll say that over the last, 10 10, 20 years, there's been a lot of things that have come out. So I do tell patients that nothing in the last 5 years, but I'll tell patients the first two steps are physical therapy. For overactive bladder, the first two steps are physical therapy or medicines.
Okay.
But if those don't work, we have other things we can offer. And there's a lot of different options depending on what you want. That's really important. What your medical history is, and don't give up, because some patients, they'll try a medicine, and honestly, medicines are about 60% effective, so they're really not that great. So don't give up. Don't give up.
Just because one didn't work.
Yeah, we can try another medicine, or we can try all these other things. So keep going to see your doctor. Don't give up, and then you'll find the right treatment. And sometimes it's a combination of therapies, and sometimes you still have to practice good bladder habits. So don't drink up until bedtime. You're gonna spend the whole night going to the bathroom. Probably don't drink coffee at 5 p.m. It's gonna irritate your bladder. Things like that. So the combination of just doing regular things throughout the day and treatment usually helps people a good amount.
And would you say the majority of people can figure it out? Women that come to you without having to take medication for like overactive bladders?
I think in general, physical therapy is about 50% effective in general. When you compare physical therapy to medicines, they're equally effective, but medicine has more side effects. You can imagine, right? There's really no side effects of physical therapy.
Yeah.
But I'll tell people, physical therapy is like going to the gym. So if you have a gym membership, but you don't use it, it's not going to help, right?
That's right.
So I tell people you have to be honest with yourself and with me. If you're going to go, because when you go to physical therapy, they teach you how to exercise your pelvic floor, but a lot of it you have to do at home. So it's a lot of homework. And then once you graduate from physical therapy, you have to keep doing it on your own. So I tell people physical therapists are like trainers. They get you trained, they get you going, but the rest of your life you have to do it on your own. And for some people, it's fine. They're like, I do my yoga and then I do my Kegels. It's fine. But some people, first of all, they're super busy, right? They're moms, they're caretakers, they have full-time jobs, so they can't go to physical therapy. So I tell them, if that's you, then you have to do a medicine, right? There's no other option. And that's okay. You're not failing. We're just finding a therapy for you. So that's really, I tell people they're both very good, very, very good options. They're pretty much equally effective. But if you can't do one, or you don't want to do the other, like some people come to me and they say, I don't want another medicine. I'm on 20 medicines, don't want another one. And I tell them, okay, go to physical therapy, and they go and they do it. So it's really what you want, but what you want is what's going to get you there, right? That's what's going to get
you. And how bad you want it.
And how bad you want it. Exactly.
And get good results.
And get good results. Now, if you try, you're all in, you try, you take your medicine every day and you don't see improvement, then that's okay. Now let's try other things. So that's when I tell people, don't worry, we're going to figure it out together.
I have a question. Can a gynecologist treat prolapse and incontinence?
So, in general, for incontinence, like to start a medicine or send you to physical therapy, they can do that. Usually, they don't feel too comfortable doing a surgery or procedure. Usually, they'll send that to us. I have seen some people in the community who do some prolapse surgeries, but in general, they'll send it to a specialized person like me, because we've done additional training, so we can handle like the more advanced situations. And also because we have just a more advanced practice. So even my nurse practitioners, this is all they do every day. So they can handle like more advanced pessaries. We have more options for them. Because we do it all, right? So in general, gynecologists will send their patients to us just because we can help them more. But starting a medicine and doing physical therapy, I think if your doctor can do that, go ahead. You don't have to come see me for that. Save yourself a trip.
I have another question.
Yeah.
After hysterectomy, can you still have prolapse?
Yeah, you can. Okay. Hysterectomy doesn't cure prolapse. We have to do other stuff to cure it. So yeah.
And also, if you have a surgery for prolapse, what's the downtime and recovery time?
So that's a good question. It really depends on the person. I find some people, I counsel them like, you're gonna be in pain for 2 weeks, and they see me and they're like, I had pain for 1 day. So it's hard for me to answer because everybody's so different. And also depends on the type of surgery. We have big surgeries and we have small surgeries. So some small surgeries, I mean, people, in all of my surgeries, patients are able to go home the same day and they're able to walk around and eat a regular diet. But how long it takes for them to feel normal, it just depends on the type of surgery.
Healing process.
Yeah.
That is such an interesting topic, but I think so many women have so many questions, and being able to talk to somebody like you, very interesting educational doctor.
Oh, it's my pleasure. I love this.
Anybody have any more questions? Do you have anything else you wanted to share with us on the subject?
What else?
Well, we are here at UAB again with Dr. Gabriela Halder. She's a urogynecologist, and we have been able to have a coffee conversation with her today about the pelvis floor, the health of the pelvis floor. And thank you for being with us today. We look forward to being able to come back and have more coffee conversations with you about
Yes.
other stuff.
Anytime. Anytime.
Thank you for being with us, Rena.
No, I love
Yadira.
it.
Thank you for being. Thank you, Gustavo, for setting it all up.
Yes, thank you, Gustavo.
Thank you. Yes.
Hi, I'm Dr. Halder, and I'm a urogynecologist here at the University of Alabama-Birmingham. And today we'll be talking about pelvic floor health. So a common question that I get is, what is the pelvic floor? And basically, so here you have what the pelvic floor is, and it's a set of bones. So these are the white part are all of your pelvic bones, and then a set of muscles. So the pink are a bunch of muscles, and then all of that holds the vagina and the urethra. So you have vagina where the baby comes out, and the urethra, that's where the urine comes out, and then also it includes the anus, and that's where the stool comes out. So the pelvic floor is really the set of muscles that hold these organs in place. So again, let's go over some pelvic anatomy to help us understand this. So here we have the bladder. The bladder is in yellow, and that's what stores urine. And then the urine leaves the body through the urethra, and that's how it exits the body. And then here we have the uterus. That's where the baby grows. That's really its only purpose in life, is to have a baby grow in it. And then that's connected to the vagina. That's where the baby comes out. And then we have the rectum that connects to the anus, and that's where our stool comes out. And so as you can see, these are the pelvic floor muscles, and so it kind of holds everything in place. It holds the bladder, the urethra, the vagina, and then the distal part of the rectum. So how do pelvic floor muscles work? So this is a side view. I think I'm trying to show you multiple views of the same thing. So this is a side view of a person. So like right here. And here we have the muscles. And the muscles are again holding in place the urethra, the vagina, and the rectum. So those are the three basic organs that it holds in place. And when it functions, it holds them in place, but it also makes sure that you have continence. So continence means that you don't void on yourself when you don't want to void on yourself, or leak urine when you don't want to leak urine, and also you don't leak stool when you don't want to leak stool. In order to do that, it contracts. But then you can imagine when you do want to void or you do want to have a bowel movement, it has to relax. So the pelvic floor holds all these organs in place, but it also contracts and relaxes depending on what you need to do. So as you can imagine, just like every other part of the body, there's things that can go wrong with the pelvic floor. So weak pelvic floor can lead to problems such as incontinence. And that's accidental leakage of urine or bowel, or it can lead to pelvic organ prolapse, which we'll go over in a little bit. You can also have an overactive pelvic floor. So that's actually when your muscles are way too strong. So you can have muscles that are too strong, and that can be bad. And that can give you pelvic pain or sometimes sexual discomfort. So these are the three things that can go wrong. if this is what your pelvic floor is experiencing. So urinary incontinence, what is it? Urinary incontinence is an involuntary loss of urine, and there's different types. The common types are stress incontinence, urgency incontinence, and mixed incontinence. So stress incontinence is when you put stress on your abdominal muscles and you leak. Stress are things like coughing, straining, bending over, exercising. So all of that increases your intra-abdominal pressure. That puts pressure on the bladder, and then that's when you leak if you have stress incontinence. Urgency incontinence, that's when as soon as you get that sensation to pee, you can't make it to the bathroom. You just like run. Before you get there, you lose urine. Some women, that is so bad that just a fleeting thought of urination comes into their mind and they just leak. So that's urgency incontinence. And then mixed incontinence is actually a mix of both types. And that's actually the most common type of incontinence. This urinary incontinence happens because of weak pelvic floor muscles. And also because of pregnancy and childbirth, aging. So aging increases the risk of urinary incontinence just in general, regardless of anything. And then also things that affect the nerves to your pelvic floor. So like diabetes can affect the nerves. Some people have heard that before. And so that can increase your risk of this type of incontinence or any type of incontinence. Treatments. So this is a big question I get. Once they say, oh, I have this problem, so how do I treat it? It really depends on the type of incontinence. So there is not one treatment that will fit both types of incontinence. So that's the important thing to recognize. They're treated very differently. So stress incontinence, for example, can be treated with physical therapy, a pessary or surgery. Urgency incontinence can be treated with physical therapy or a medicine. But the contrary, medicines can't be used to treat stress incontinence. So you have to be careful. Sometimes people think, oh, I just want a pill to make this incontinence better. My friend got a pill, her incontinence got better. But if your type of incontinence is different, if you have stress incontinence, it won't get better. Kegel exercises, what we talk about when we talk about strengthening the pelvic floor. And that can be used for both types of incontinence. That is the only treatment that can be used for both. And then we have, of course, dietary changes such as avoiding caffeine. And when I say avoiding caffeine, you don't have to completely stop caffeine. I know for us that would be like awful. I love my cup of coffee in the morning. But once you start hitting about 6 cups of coffee a day, it's just so overwhelming for the bladder that you'll just have urgency, frequency, and puts you at risk of urgency incontinence. But anything less than that, you should enjoy your coffee. If you're the type of person that's very, very, very sensitive to coffee, then maybe you might consider cutting down, but you don't have to completely give it up. And then alcohol, that increases your risk of it makes the bladder irritable and it'll make you run to the bathroom. And there's just certain medications that will increase your risk of leakage, but it just varies by medication. And then certain surgeries that someone can have can increase the risk of leakage too, but it's just certain surgeries in general. Okay, so I said we would talk about pelvic organ prolapse. So here we have a normal pelvis. So this is the pelvic bone. Here we have the bladder and urethra, the uterus and vagina, and the rectum. And they're sitting here. You can't see the pelvic floor, you just see the bones, but it would be there. If you have prolapse, you'll notice now that the uterus is much lower. And the vagina now has a little bit of a bulge, right? Because the vagina is weak. Mm-hmm. So prolapse, I tell people, is a problem not of the uterus, it's a problem with the vagina. So when your vagina isn't appropriately supported by your pelvic floor, then it can prolapse. So I tell my patients, think of, like, if this room is a giant vagina, these are the walls, the vaginal walls, right? So if the walls are weak, what happens? Everything starts caving in. The wall would cave in. The floor is still weak. That's how a vagina works. And so up in the roof, that's where the uterus and bladder are. And then down below, that's where the rectum is. So when you have bladder prolapse, your bladder isn't prolapsing out. It's just the vagina that sits on top of the bladder is coming out. When you have rectal prolapse, it's not the rectum that's prolapsing out. It's the vagina over the rectum. And so we kind of went over, there's different types of prolapse. that bladder prolapse is the vagina open. It's the toe of the bladder that comes out. Uterine prolapse is when, like, the part of the uterus, the cervix is the most common, is the part that's coming out the most. We talked about rectal prolapse, and then apical prolapse is essentially the same thing as uterine prolapse, but some people have had a hysterectomy and they don't have a uterus, and so it's the top of the vagina that comes out. In the end, what type of prolapse that you have can give you different symptoms, but in the end, everything is treated the same. So I tell my patients, don't worry too much about the type of prolapse that you have, because the type of treatment that you get is the same. Common question is like, how did this happen? And really the greatest risk factor for prolapse are vaginal pregnancies and births. So the greatest risk is vaginal birth, and before that is just being pregnant in general. So, but babies are so cute, right? Like, you gotta have babies. But that is the greatest risk. It's not, I get a common question of, did I do this to myself? I lift heavy things. That's not, we really don't have evidence to support that. So don't feel bad. If you've been someone that lifts heavy things, that's actually really great. You're probably really healthy and you have a lot of muscle mass, and you shouldn't feel bad that you did that. We talked a little bit about this. Older age and menopause, just like it increases the risk of incontinence, it also increases the risk of prolapse. Chronic constipation. So if you are constantly straining, that pushes pressure on the bottom part of the vagina and increases your risk of prolapse. And then, of course, genetics. Just some women are just more susceptible to prolapse than others, unfortunately. Someone will tell me, what are the symptoms of prolapse? And really it's just a heaviness, a sense of heaviness in the pelvis. It's not pain. So some women will come see you and say, I have pain, I think I have prolapse, but that's really not a common symptom of prolapse. It's just pressure. So usually women will say, I feel pressure. It's really worse at the end of the day when I've been up on my feet all day and I just feel like something's coming down. I feel like something's hanging out. I see something that's hanging out. I feel like I'm sitting on something. Those are the more common symptoms. And then, yes, women that have prolapse can have incontinence, but women with prolapse don't necessarily have incontinence. It's not a rule. Even though everything in the pelvis is related, you have the same muscles and bones and things like that, you can have prolapse with incontinence, prolapse without incontinence. Just like if you have incontinence, it doesn't necessarily mean you have prolapse. That's a really important thing to take away from this, is you can have one or the other. Commonly you have both, but also a lot of times you just have one or the other. The treatments for prolapse is physical therapy, which includes Kegel exercises. And again, that's just learning how to strengthen your pelvic floor. A pessary, and those are just devices that you put in the vagina that holds it in place. It's a device that's made out of rubber, and you learn how to take it in and out. And then, of course, you can have surgery. But you don't have to have surgery. You can try any of these methods. Okay, and then last, fecal incontinence. So fecal incontinence is when you have accidental bowel leakage. So you accidentally leak stool when you don't want to leak stool. And there's lots of different causes. One of them is weakness of the pelvic floor. 2 is nerve damage. 3 is gastrointestinal disease. So if you are someone that struggles from chronic diarrhea for whatever reason, maybe you have ulcerative colitis or chronic constipation that leads to diarrhea, it's very hard to maintain fecal continence when you have diarrhea. I mean, even for young 20-year-olds, it just increases your chance of you stooling on yourself. So that's one thing we address when people come to the clinic and they have fecal incontinence, is starting with the basics. Let's make sure you're eating enough fiber. Let's make sure that you don't have diarrhea, because I can't really help you otherwise. And that helps a ton. Some women that we just do that and it goes away. Again, older age can affect, it increases your risk of fecal incontinence. And we talked a little bit about symptoms of fecal incontinence. It's inability to control the stool, whether liquid or solid. You usually have a sensation of urgency, so you as soon as you get the urge to have a bowel movement, you can't control it. So normally a normal person can say, right now is not a good time to have a bowel movement. I'm in the office, and you can hold it, but people who have fecal incontinence just can't do that. Some people will lose stool while they're sleeping, or just in everyday situations. And it also includes accidental leakage of gas. So we include that in, it's not actually called anal incontinence, but it can be a symptom too. We talk about treatments. Physical therapy, again, is a treatment for everything. And again, I just hit on this previously, is fiber really helps in this type of situation. And it also helps with constipation, and it's just overall good for you. So fiber can be a really good place to start. There's also some anti-diarrheal medicines. If the reason why you're having fecal incontinence is diarrhea, then anti-diarrheals like Imodium can help. And then we talked about physical therapy. Surgery is an option for fecal incontinence, but it's generally not the first approach that we try because we really don't have many surgeries to offer. And even in those surgeries, you still need to do all these other things like manage your diarrhea, manage your constipation. You always have to do that.